Hello, my name is Dr. Bill Gray from the Lankenau Heart Institute, and I'm here to present the DISRUPT PAD3 randomized controlled data 30-day outcomes on behalf of the investigators. Endovascular treatment of calcified peripheral arterial disease has been clearly shown to be complicated by restrictions in arterial compliance, poor balloon expansion, and dissections with acute procedural failure. It appears to influence the effectiveness of DCBs by limiting drug uptake and requires stent to address PTA failures that might themselves fracture or otherwise complicate future interventions. Distal embolization, dissection, and perforation remain a concern with atherectomy treatment, and patients with moderate to severe calcifications are often excluded from endovascular trials. Therefore, there is little available evidence to provide treatment guidance in this challenging patient population. We typically extrapolate data from less severely calcified trials to inform our treatment decisions. Intravascular lithotripsy was specifically introduced to address these calcified lesions, and it works by delivering balloon-based catheter across the lesion and inflating to a low pressure, about 4 to 6 atmospheres. Sonic waves are then generated inside a fluid-filled balloon, which creates an effective pressure of about 50 atmospheres outside the balloon that cracks the calcium in situ and allows the vessels to expand at a low atmosphere. If we look at this micro-CT analysis from Renu Vermani, we can see the pre-interventional calcification of this vessel. Following treatment with intravascular lithotripsy, you can clearly see the fractured calcium and again in situ without embolization. This materially changes the compliance of the vessel and allows expansion. Here's an actual angiogram from a total occlusion of an SFA with heavy calcification from the PAD3 study. It was crossed with standard techniques and then ballooned with a shockwave IVL device in 2 different locations, using a maximum of 6 atmospheres. You can see following IVL and no other treatment that there was less than a 20% residual stenosis with acute gain of almost 5 millimeters. A 60 millimeter DCB was delivered and inflated, resulting in a final stenosis of about 20% and an acute gain of 4.5 millimeters. As you can see, IVL achieved most of the gain at low pressures and prepped the vessel nicely for DCB. The peripheral IVL clinical programs are actually quite robust. DISRUPT PAD 1 and 2 were relatively small trials done outside the United States for both proof of concept and signal generation. DISRUPT BTK was also a small trial done outside the United States, looking at the same technology but below the knee. This morning we're going to speak directly to the DISRUPT PAD 3 randomized trial. I will go into more detail in a moment. There's also a very large 1,500 patient PAD 3 observational study that is being done around the world. This particular trial, DISRUPT PAD 3, is a global randomized clinical trial. It was a prospective, multi-center, single-blind, randomized controlled trial. The objective was to compare the safety and efficacy of intravascular lithotripsy plus DCB versus PTA alone with DCB for the treatment of moderately and severely calcified femoral popliteal arteries. The statistics are such that there's a superiority analysis performed for both the primary and secondary powered endpoints. In order to get into this trial, you basically had to be excluded from all other trials for SFA disease. That is, you had to have moderate and severe calcification in order to get in. There were 306 patients randomized at 45 global sites, about 150 patients in each arm. Patients were treated with intravascular lithotripsy in the one arm and PTA in the other arm. All patients received impact DCB for their finishing antiproliferative treatment. Patients who had a residual stenosis greater than a certain degree or a significant dissection, which I'll go into in a moment, were then allowed to have stent placement as needed. There was a 30-day follow-up, which we're reporting today, and there will be 6 months, 1 year, and 2-year follow-up as well. The primary endpoint is procedural success. That is important. It is not a 1-year primary endpoint. This is a procedural endpoint. It's defined as a residual stenosis of less than or equal to 30% without flow-limiting dissection that is either grade D or worse by angiographic core lab analysis prior to the DCB or the need for stenting prior to DCB. This is schematized here. Pre-procedural core lab analysis, randomization to either IVL or PTA, followed by post-treatment assessment of stenosis severity. That is the endpoint. This is followed by treatment with either DCB plus or minus a stent as declared by the operator on site. Then the final result. The secondary endpoints include major adverse outcomes, 30-day CDTLR and ABI, Rutherford classification, and the walking improvement questionnaire. The powered secondary endpoints at 12 months is primary patency. That will be an interesting analysis. The acute PTA failure that might occur at the time of intervention will also be counted as a primary loss of patency. And the freedom from clinically driven TLR and freedom from restenosis determined by duplex ultrasound or angiogram will also be in that mix. These are the key clinical and angiographic eligibility criteria. I'm not going to go through all of them. They're fairly standard. The only one I'm going to call out is that patients had to have a lesion length of less than 180 millimeters, and that's a pretty robust lesion length. These could also include CTOs of less than 100 millimeters of the total 180 millimeter target lesion. Calcification had to be greater than or equal to moderate, as defined by the evidence of calcium under fluoroscopy, with calcium on parallel sides of the vessel extending at least 50% the lesion length, or a minimum calcification length of 20 millimeters. The exclusion criteria are listed here. And different from most PAD studies, you had to have significant calcification in order to get in, and you were excluded if you didn't. I was the co-principal investigator with Gunnar Tepe, and I'm very pleased to present this on his behalf. The clinical events committee was run by Luis Gamboni, the angiographic core lab by Alexander Lansky. The safety monitoring and data management statistics were by Jessica Johnson out of ClinLogix. This is the stellar group of principal investigators, and I want to give them a full credit for running a terrific trial in difficult times. It was done in part during the paclitaxel controversy, and obviously that creates its own challenges. The group did a really terrific job in recruitment and follow-up. Here's the consort diagram. 306 patients, about 150 patients in each arm. Primary endpoint images are available in 146 patients of the lithotripsy group and 133 patients of the PTA group. We have 30-day clinical follow-up in all but one patient in each group. So far, very good follow-up. The baseline characteristics are not different between the two groups, save for a little bit more smoking in the PTA arm. The majority of these patients were Rutherford 3 and a smattering of Rutherford 2. Again, not different between the two groups. There were no material differences between the baseline lesion characteristics. Note that their lesion length was almost 10 centimeters, and 10% of those had lesion lengths of over 150 millimeters. The calcified length of these lesions was approximately 130 millimeters in each arm, and severe calcification, as judged by the core lab, was present in almost 90% of all lesions. You can see that arterial segment resided primarily in the mid and distal SFA. This is truly a challenging set of patients. Here are the procedural characteristics. You'll see that there are a few differences between them. Fluoroscopy time was a little longer in the IVL arm, and the majority of PAD 3 was completed with a prior generation of device which had only 180 pulses per balloon. This generator was changed partly through the trial and now allows 300 pulses per catheter. With the new generator, we rarely need more than one IVL device in a case. As you can see, post-dilatation and stent placement were significantly more likely in the PTA arm as compared to the IVL arm. IVL also had low single-digit incidence of post-dilation or stent placement. You can see that the maximum inflation pressure for IVL was 6 atmospheres, as compared to PTA, which was 11 atmospheres. So with IVL, we had significantly lower maximum inflation pressure required, along with a 75% relative risk reduction for overall stent placement. And when we look at the core lab adjudicated diameter stenosis, we see that about 2/3 of patients after IVL achieved the primary endpoint goal of less than 30% residual stenosis, as opposed to only about half the patients in the PTA arm. If we look at the mean diameter stenosis, IVL has significant improvement over the PTA arm prior to any further intervention. Looking at the core lab adjudicated dissections, we see that types C and D were significantly higher in the PTA arm as compared to the IVL arm, which achieved a 77% relative risk reduction in the rate of these clinically meaningful dissections. The primary endpoint in DISRUPT PAD 3 is procedural success. Both site-reported and angiographic core lab favored the IVL treatment in this regard. There was a 25% differential between treatment successes when site-reported and a 15% overall improvement when core lab adjudicated. Both were achieving highly statistically significant differences. When we look at the final angiographic and clinical outcomes, that is, after further balloon dilation or stent implantation as dictated by the operator, we see that no real difference between the two exists. So PTA ultimately did catch up after extensive further intervention with either PTA or stent implantation. 30-day safety endpoints are not different between the two therapies. Notice that distal embolization does not occur with IVL. This has been seen in other IVL trials, both in the coronary and peripheral spaces. Perforation is also not routinely seen after IVL treatment. To contextualize these data, we compare the core lab adjudicated Disrupt PAD3 results to the core lab adjudicated data from the first 200 patients in the PAD3 observational study, which have been already reported. We see that pre-procedural lesion stenosis was roughly the same between the two studies, and post-IVL was roughly the same, and the final outcome, again, very similar. So these PAD3 randomized controlled data can stand on their own or in context with a larger data set from the PAD3 observational study. If we look at the complications angiographically, we see that they are consistent across the board for more than 350 patients in the two trials. In conclusion, the Disrupt PAD3 randomized controlled trial provides the largest level 1 evidence for the treatment of heavily calcified femoropopliteal arteries in a difficult-to-treat cohort that has often been excluded from prior trials. Intravascular lithotripsy was superior to PTA in acute procedural success and demonstrated an atraumatic treatment which reduced diameter stenosis prior to DCB or stent placement with a lower maximum inflation pressure, reduced frequency and severity of dissections, and lowered post-dilation and stent implantation rates significantly. The randomized controlled trial outcomes are similar to the PAD3 observational study, real-world registry, in multiple vessel beds, which highlights the consistency of the IVL treatment among the complex anatomies. Powered secondary endpoints and primary patency at 12 months will be analyzed following appropriate follow-up for all enrolled patients. Thank you very much.